So the risk of anesthesia as given in pre-op risk depends on the interaction of anesthesia, surgery, and patient factors. These are the three things which are interrelated. So morbidity and mortality within 30 days of post-op are considered as risk related to anesthesia and surgery. So it is not only on the table or immediate post-op complications. Any morbidity or mortality happening 30 days post-op after any surgery is also included in the risk for related to anesthesia and surgery. So anesthesia is a double-edged weapon. In some cases, it may be the cause for the morbidity and mortality, increasing the risk. As for example, when you try to give an epidural and you make a total spinal, it can become disastrous sometimes. Okay, or you try to you go in for a failed intubation and you are not able to ventilate, not able to intubate, then you can end up with a very great problem. So it can, so anesthesia can be the cause for the morbidity and mortality, but at the same time, in some other patients, it can decrease them or modify the risk related to patient diseases and make them undergo surgery without any complications. For example, a patient with a coronary artery disease needing a CABG, his ejection fraction may be only 30%. But if you do the CABG successfully, his heart is going to improve. So you manage them with judiciously using all your drugs. That may be the advantage of using anesthesia. So post anesthesia, respiratory depression has been found to be the major cause of death and coma in majority of the cases. And this risk prompted the development of post anesthesia care units. So earlier, even when I started my PG training, there was no separate post anesthesia care or recovery area. All patients, however much, whether they undergo laparotomy or tonsillectomy or hydrocele circumcision, everybody will be sent back to the same ward from there, from general ward from where they came, or the special ward from where they came. After the development of such complications after anesthesia and surgery, then they thought we have to monitor all the patients undergoing anesthesia and surgery at least for 12 to 24 hours in a separate area and not keep them in the general ward like other patients who are ambulant and who can take care of themselves. And that prompted the development of post anesthesia care unit. In anesthesia related cardiac arrest is attributed mainly to medications, airway management, or complications due to central venous access. These are the common causes they found could be the cause for cardiac arrest apart from the respiratory depression. To reduce factors associated with increased risk, they developed risk indices so that pre-operatively you can find out who are all the patients at higher risk and then take extra care or use techniques which will produce less complications in them. Example is the cardiac risk index which we use nowadays for patients with ischemic heart disease. And then surveys conducted to assess maternal mortality in obstetrics has shown that regional techniques have reduced the risk involved compared to general anesthesia. And pediatric perioperative cardiac arrest registry has shown that medication related and cardiovascular causes are the most common causes of risk of cardiac arrest in pediatric population. And with daycare surgery becoming more accepted, it has become important where you conduct the surgery and whether the theater that you are using for daycare procedures are all well equipped to meet any complications to reduce the risk of anesthesia. So this diagram shows how they are interrelated. You have anesthesia, which is manned by anesthesia provider characteristics, and if any errors in judgments are made or unanticipated mishaps, all these things lead to anesthesia related risk. Surgery errors again in judgment by the surgeon or the location of postoperative care. These are the factors which affect the surgical outcome. And patient diseases, surgical disease, age and sex comorbidity, all these things lead to the outcome which can be either death major morbidity, minor morbidity, readmission, or a very satisfied patient going home happily on the designated day. So these are all the outcomes. This is how the whole risk has been tabulated. So the first formal investigation of anesthesia-related death was by John Snow, as I told you, for chloroform deaths in 1858. Then Sir Robert McIntosh. Does that name sound a bell? Who is Robert McIntosh? Gopika.
Sir,
His contribution to anesthesia. Huh?
some laryngoscope plate.
Laryngoscope itself, not blade alone. He was the inventor of
Yes, sir.
McIntosh laryngoscope with a curved blade. Okay.
Yes, sir.
So 1948, he investigated the many anesthesia related deaths were preventable, and he said improve education. In fact, he became so virulent to talk that you stop all drug production, improve the training of your anesthetist, because in those days only MBBS graduates were giving anesthesia. So
Yes.
they were just trained, and they were asked to do just like the theater technicians. So they never had a basic proper education on their physiology, pharmacology, and anesthetic related drugs and techniques. So he insisted that everybody should be properly trained before they give anesthesia to prevent the deaths and mortality. And then in 1954, Beecher and Todd published their analysis on anesthesia-related risk, which revealed anesthesia as a primary cause of morbidity and mortality in 1 in 2,680 procedures. Okay. Then there was Edwards' classification of anesthesia to operative morbidity and mortality, in which he classified 4 categories. The first category, morbidity and mortality, occurred definitely due to anesthetic agent or technique. This is classified as category 1. And category 2 is similar to this, but there is a certain element of doubt whether anesthetic agent or technique could be the cause for the morbidity and mortality. In category 3, the morbidity and mortality share the equal responsibility from both anesthesia and surgery. And in class 4, it is purely a surgical error and surgical cause. So that is how Edward classified the anesthesia risk, which is again operative morbidity and mortality. Now we saw about AIMS in the last class. What is the expansion of AIMS?
Anesthetic Information Management System.
Anesthetic Information Management System. Okay. After the usage of extensive adaptation of AIMS for the recording of perioperative events, which we saw in the last class. So that has using computers to procure, store, and analyze data. This has become an easy way to analyze the morbidity and mortality and thereby the risk of anesthesia. So several investigators, among which Sanborn and colleagues, were the first people to use this AIMS system to analyze the morbidity and mortality and classify whether, according to Edwards' classification, whether it is purely an anesthetic fault or a combination of anesthesia and surgery or a purely surgical fault. All that could be analyzed from the use of AIMS, and later Rich and colleagues used have done extensive work on this. And other approaches were used to find out the root cause of morbidity and mortality, that is COPD, CPOD, Confidential Inquiry into Perioperative Death, UK, ASA Closed Claim Study in USA, Australian Incident Monitoring Study. All these things went back into the patients who had morbidity and mortality and then analyzed that and then found out what is the cause. Now coming to the risk factors, the risk factors associated with increased odds of dying within 7 days are classified like this. When the patient's age is higher, the odds are 2.2 to 3.39. That is 80 plus, the mortality is more. And sex, the ratio female to male is 0.77. Physical status score, again, if it is between 3 to 5, the risk is more. If it is less than 1.2, risk is less. When surgery related, it can be major, minor, intermediate, length of surgery or the duration of surgery, and whether the surgery is emergent or elective. All these things carry varied odds of dying in 7 days. And lastly, anesthesia related, it depends on the experience of the anesthetist, whether only inhalation, both inhalation and narcotic were used, or whether it was a isolated narcotic or inhalation used, whether it was a spinal anesthesia, or how many number of drugs were used. All these things have a bearing on the odds ratio of the patient dying within 7 days. And the special patient groups who have this problem are obstetric patients. That is why we had the inquiry into the maternal death, obstetric CMAC, which is being utilized. So that evaluates the obstetric patients' mortality rate, and pediatrics, geriatrics. These three groups of patients have a special bearing on the perioperative morbidity and mortality. Apart from all these risks for the patients, anesthesia is also a risk. The risk of anesthesia includes the anesthesiologist also, and that is they are more prone for medical legal risk. They can develop allergic reaction, especially latex allergy and other skin problems, needle stick injury, disease transmission, especially HIV, and they can develop drug dependence. So all these things belong to the risk that is anesthesiologists are exposed to. So I think this is the way the entire chapter deals with the risk of anesthesia, and I don't know, you have to refer to other senior current professors or senior people who are experienced in correcting the DNB answer papers. You have to consult them whether this answer is correct or what you have prepared is correct. I'm not at a loss not to comment on your preparation now. Okay.
Yes.